working in Paris. She's involved in a number of studies and evaluation of quality assurance in radiotherapy in the setting of adjuvant therapy and locally advanced pancreatic cancer. Thank you.
Thank you. First, I would like to thank the organizers for their kind invitation. I don't want to thank them for the question and for the subject of the topic because I think it's quite difficult. I had to work a lot to try to give you a good talk. And my first question was, what is the rate of R1 resection in pancreatic cancer? So I have looked at the most important prospective studies published during the last 20 years in the pancreatic cancer field. And you can see that the rate of R1 resection varies from 13 to 34% of patients. But what does R1 resection mean really? My colleagues have already talked about that a little this morning and this afternoon. In this very important study published in 2008, Aaron Esposito showed that with a standardized pathological procedure with a definition of R1 margin of 1 millimeter or less, the rate of R1 resection was of 76% compared to 14% in a control group without standardization. The most involved margin was the vascular margin in 68% of the specimens. What is the definition of the resection margins? There are two definitions in the literature. The first is the definition of the AGCC, and you see that it's a very unprecise definition because they said R1 is grossly negative but microscopically positive margins of resection. So with that, you can do what you want. And the second definition, which is a little more precise, is the definition of the Royal College of Pathologists, which says that carcinoma less than 1 millimeter from a resection margin is considered to be incompletely excised. But there are many margins on a pancreatic specimen. You have two kinds of margins. First, the transection margins, which are the pancreatic neck, bile duct, and gastric and duodenal transections margins. And second, the dissection margins, which are mainly the arterial and venous margin around the SMA and the portal vein SMV. There is the posterior margin too that you can see here. The margins should be inked to be able to analyze them properly. So you see here the venous margin, the arterial margin, and the posterior margin. And if you ink the margins properly, you can define the status of your margin. But if you change the width of the margin, you can see that the rate of the R1 resection change a lot from 23% if you take 0 to 71% if you take 2 millimeters. So keeping that in mind, we are going to see which data we have about adjuvant treatment after pancreatic resection. So I agree with all the surgeons who have talked before me today. The only curative treatment for pancreatic cancer is surgical resection. Unfortunately, the median overall survival after surgical resection in historical series is around 20 months with a 5-year overall survival rate of 20%. And a high risk of relapse in about 80% of cases. What do we know about adjuvant chemoradiation? I haven't told you that I'm a radiation oncologist. So we know that chemoradiation could be better than observation, but that has been shown in only one prospective study with very few patients. You see, only 49 patients. The EORTC study, which was made just after with exactly the same radiation therapy schema, showed no benefit. And since this moment, we had a separation between Europe and US. Chemoradiation became the standard in US, and chemotherapy became the standard in Europe. After that, we had the results of the seminal studies SPAC1, and everybody knows this study, and you know that the conclusions of this study, that there was a benefit of adjuvant chemotherapy and that chemoradiation was deleterious for patients. If we look at the rate of R1 resections in this study, it was about 19% of patients. So keep in mind that doesn't seem to be a lot. And the overall survival of patients with R1 margins was lower compared to patients with R0 margins. And if we look at the benefits of chemotherapy or chemoradiation in patients with R1 disease, you can see that chemoradiation wasn't better than chemotherapy in this subset of patients. But remember that radiation therapy in this trial has done with very old techniques of radiation, with split course techniques, as some speakers have already said today. There has been a meta-analysis. A first meta-analysis published in 2005. I have hesitated to put it because it isn't a very good meta-analysis. It's on published data and not on individual data. And this meta-analysis included only 5 studies. But I think it's important because this meta-analysis confirmed the SPAC1 results and showed that in R1 patients, we could have a benefit of chemoradiation. So that was the first study to show that. And since the results of this study, some people have believed that in R1 patients, we should do chemoradiation. So we are going now to see if there are some evidence to support this. Adjuvant chemotherapy is now the standard of care since the publication of the results of CONCO-1 trial, which shown benefits in disease-free survival and overall survival in patients after pancreatic resection. In this trial, there was a benefit for gemcitabine in R0 and R1 patients. The Japanese trial has confirmed these results in Japanese patients. The SPAC3 trial has randomized the patients, more than 1,000 patients, between an adjuvant chemotherapy by FUFOL and an adjuvant chemotherapy with gemcitabine during 6 months. And you know that there was no difference in terms of overall survival between the 2 arms. And in this trial, there was 35% of patients with R1 margins. And the prognosis and the overall survival of patients with R1 margins was less good than patients with R0 margins, confirming what we know. We have only one. No, it isn't the only one, but there is this important trial with radiation therapy in the adjuvant setting, but which isn't very useful for us today because there was chemoradiation in the 2 arms. The thing was, it was to compare a chemoradiation with a sandwich of chemotherapy by 5-FU or by gemcitabine. There was no difference between the 2 arms. There was a slight improvement in overall survival for patients with pancreatic head tumors in the gemcitabine arm. And there was, as in SPAC3, 35% of patients with R1 margins. What could be interesting in these trials is that there was no difference in overall survival between R0 and R1 patients. So we could imagine that this absence of difference in survival could be linked to a benefit of chemoradiation. And after that, there has been a lot of huge retrospective series published, mainly by American, with a percentage of R1 margins between 15 and 30%, like in prospective trials. And you see that most of these series, no, not most, all these series showed that there was a benefit in overall survival in favor of chemoradiation. But these series are retrospective, and there are major bias because most of them have been done in US, and in US, chemoradiation is the standard of care, so there is a high bias of selection. I just want to highlight this one. It's the most recent published. It's a survey by the Mayo Clinic with 458 patients. And so they compared patients who received adjuvant chemoradiation versus no chemoradiation. And in the chemoradiation group, the local regional control was better. You see 80% versus 68%. And there were 16% of patients with R1 resection, and among these patients, 84 of them had received chemoradiation. So this could be in favor of a local effect of chemoradiation. So we have already seen this table with the rate of R1 margins, and now if we look at the rate of local regional only recurrence, you can see that we have between 15 to 35 local regional recurrence. And if you look at the trial with radiation therapy, like the 2 EORTC trial, and the RTOG1, you can see that the rate of local regional recurrence seems to be a little lower than in the chemotherapy studies. But it's still high, so an improvement in local regional therapy is mandatory. This is a very interesting slide that Professor Del Perro has given to me. It's a prospective French study with more than 100 patients, and you can see the overall survival of patients depending of the status of the margins and of the node, of the lymph node. And you see that R0 and 0 patients have very good prognosis. N+ patients have a really bad prognosis and independent from the margin status. And you have this group of patients in the middle. And so perhaps these patients could benefit from chemoradiation. So we have two treatment options. So chemotherapy and chemoradiation. Why oppose them? We could rather try to associate them. As you know, in the locally advanced setting, we have set the LAP07 trial. In this trial, patients received first chemotherapy during 4 months, and then, in absence of progression, they were randomized between 2 more months of chemotherapy or chemoradiation. As you know, there was no difference in terms of overall survival between the 2 arms, but there was a trend in favor of chemoradiation in PFS with a p-value of 0.055. And if you look at the first site of progression in patients who were randomized, you can see that the rate of local progression was higher in the chemotherapy group than in the chemoradiation group, showing that there is an efficacy of chemoradiation on local control. In adjuvant setting, chemotherapy combined with chemoradiation has been studied in the EORTC FFCD-JACR trial, published in 2010 by Jean-Luc Van Laethem. And in this trial, all the patients had R0 resection. The overall survival was similar in the 2 arms. It was 24 months, which is good. But there was less local recurrence in the chemoradiation therapy arm. We have seen it was only 11% of local recurrence. What we can say after the results of this trial is there is no benefit of chemoradiation in R0 patients. Recently, LIO has published in Lancet Oncol a meta-analysis about 10 prospective studies and conclude in this meta-analysis that the best regimen could be chemoradiation and gemcitabine. If you look here at the hazard ratio, but it is the most toxic. So here you have toxicity and survival. This one is the most toxic, but perhaps the most efficient too. You have to be very cautious about the conclusion of this meta-analysis. These patients are only the patients in the RTOG 9704, which are in the arm gemcitabine chemoradiation gemcitabine. So it's a very low number of patients. In US, the RTOG 0848 phase 3 trial is ongoing. Patients are randomized first between 5 months of gemcitabine or gemcitabine plus erlotinib, and then in absence of tumor progression, they receive chemoradiation or not. In this trial, there is a stratification in function of the status of the margins. In parallel of this trial, they have done a huge work about the definition of the targeted volumes in the adjuvant setting, because every radiation oncologist in the room knows that it's quite difficult to define and to delineate the volumes to treat after a surgical resection. So I encourage you to read this very good paper. And as Karin Osterman told us this morning, IMRT is one of the new techniques that can improve the efficacy of radiation therapy by improving the differential effect, that is a better coverage of the target volume of the tumor and a better sparing of organ at risk, which improves tolerance, as you can see in this study. So we have seen this slide already today too. But so you can see that after resection with an adjuvant treatment, the median survival range between 20 and 25 months. But with a neoadjuvant treatment followed by resection, you can observe the same median survival time. Neoadjuvant treatment allows a high rate of R0 resection. And if we look at the results of the German consort trial, as you know, this trial was closed because of low accrual after 60 patients. So there are not enough patients to conclude. But if you look at the pathological staging in this trial, you can see that there was a higher rate of patients with PN0 in the chemoradiation arm, and a higher rate of R0 resection in the neoadjuvant arm. So in conclusions, adjuvant chemotherapy is a standard of care, which is the best regimen now. There are two phase 3 trials ongoing, PRODIGE 24 and APACT trials, who compare gemcitabine and FOLFIRINOX and gemcitabine and gemcitabine plus nab-paclitaxel. There is a huge problem of definition and assessment of resection margins. So we need a standardized protocol for specimen examination, because if we let things like that, we are not going able to compare our results. There isn't solid evidence for benefits of chemoradiotherapy in this setting, even for R1 patients. So we need to wait for the results of the RTOG 0848 trial. And my question is, perhaps the best adjuvant treatment is a neoadjuvant treatment. Thank you.